So first you must think about the etiology. If it is congestive heart failure, you might consider to give himself furosemide and not puncture if it's bilateral. But if it's unilateral, we usually do want to diagnose it and or alleviate symptoms if we know the diagnosis, such as lung cancer and so on. You have to think whether it's safe enough to do it. And of course you have to think and verify whether this patient is receiving anticoagulation at the moment and what type of anticoagulation. So let's take a look. I have this ultrasound probe here, okay? And I have the indicator over here. I don't have it over here. So I put the indicator in the longitudinal position on the patient, okay? And I'm looking here. What I see here, I see the ribs and the rib shadows here. And I see here the liver, the diaphragm, a lot of fluid. Actually, it's not so much. It's about, I would call it moderate. Let's take a little bit more of depth. I like to see what I'm doing. That's better. Okay. And now let's take a look. So we have the liver here. If you remember the longitudinal position, the patient's head is on the left side of the screen and the patient's legs are on the right side of the screen. So this is why I see here the liver inferiorly. I see the diaphragm. Sometimes it is obscured by the rib shadow. And here I see a lung which is collapsed. And I see just the tip of it. And all the rest of the black area here is fluid. So I can definitely perform the procedure quite nicely. And I do take another look, going a bit up to see what's going on there. This is much too close. If I puncture here, I will maybe get a bit of fluid for a split of a second, and then the rest of the needle will be inside this lung, and I won't get anything. Okay, this is one of the reasons why when you do it with ultrasound, it's so easy. So I go to a place somewhere. Of course, if I go too low, I will make actually a liver biopsy, which I don't intend to do. So I have to be somewhere in the middle, around here. Okay, and then again, a few possibilities. One is just to say, okay, this is where I need to be, and then take the ultrasound out and start palpating and see what's going on. Okay, and that's it. And I'm done with this. What I usually do if I'm not using it on a continuous level, I will take a syringe and I will just do a mark on the patient's skin. I'm not using markers because when I put the alcohol, the markers will be out. So I'm putting a little mark on the skin with the plastic, and I'm verifying again that I'm in the right spot, and that's it. This will stay for about 2 minutes. Now I will clean the patient, I will anesthetize the patient, and I will stick my needle inside. That's it. So this is one possibility. The other, which I'm going to show now, is how I do it under ultrasound guidance. And what I will do now is to move from a longitudinal position to a transverse position. When I do it here, okay, if I will put myself on top of a rib, I won't see anything. See? Nothing. But if I put it between the ribs, now I can see something. Okay? And I see here the liver with the diaphragm. Okay? If I now turn cephally, I may see some lung, which I don't see at the moment, so it's a good place. If I turn it towards caudally, I see that I'm quite close to the liver. So I have to be in my angle in this place where I see there's a nice long way I can go with the needle. I can also try to see if a better place is, if one rib up and down, what will that give me? So if I put myself one rib up, as you can see, I will hit this lung over here. It's not what I want to do. Okay, the lung is much too close now. This is the lung, this is the collapsed lung, the so-called dolphin sign. So definitely I don't want to go in here. I have to be very specific. Probably I will not succeed. I'll just get a bit of fluid and then I'll already hurt the lung, and of course that could cause me pneumothorax, which I don't want to. So I will go back to the best place I found. I can also down one bit, too close. Here is fine, okay? And of course the angle in which I work is very important. So after I establish the place in which I want to puncture, I still have to palpate and see that I'm in the right place. So if you remember, the neurovascular bundle runs beneath the ribs. So I must put my needle above the rib. So if I have the intercostal space here, I have one rib here, I have one rib there, I must go above a rib, either here or here, never here. So now I am switching hands. I positioned it in the place I want it to be. Now I'm switching to the left hand, which I'm holding very firm, and I will take the needle now. As you see here, we have the needle, which we will be able to see on our simulator, and here we have a syringe, and it's a good idea to put a new syringe in because you have also to practice the tactile feedback of opening a new syringe. Usually you have to put a bit more force to open it in the first time. So you have to practice that. So when I get a syringe, the first thing I do is first of all to open it and close it again. The next time I'm going to use it, it's going to be completely smooth. Otherwise you're kind of stuck within the patient and you don't know what to do. So now I'm going to take the needle, okay, and I'm going to show you how I put it inside, either in plane or out of plane positions. The idea about in plane and out of plane, if it's in plane, I will be able to see the whole length of the needle, and if it's out of plane, I'll only see a dot. So let's see how it looks. I'm placing myself in the right position, holding it with my left hand, and I'm going to use my dominant hand, my right hand, to put in the needle. So I'm going to palpate here. Okay, I'm just above the rib, and then I'm going to insert it. This time I'm doing it in plane, which means that the needle is parallel to the probe. One important thing is to do it fast and sharp. Okay, so I can see that I'm in line with the plane of the probe. Okay, and here I go. Boom. See I can see the needle here. It's already inside the pleural space. Okay, and I'm not so close to the liver, quite safe. I can go a bit more, and I can get a bit deeper. Okay, so I'm quite close to the liver now, and I may get a warning. Needle is advancing towards the liver. This is of course something we don't get in real life, but it's nice to have on a simulator. I don't need to do more than that. I can now just touch the start suction button and watch how the fluid is slowly getting out. Another possibility is to perform the procedure in out-of-plane technique. It means that the needle is not in plane with the transducer, but is out of plane, which means that I will only see a dot, and I don't know where I see it along. It could be here, it could be there. I could see this part and to have 7 centimeters deeper than that, which I don't see. So this is the problem with this technique, but sometimes it could be helpful if you're very careful. So what you can do is use it in this way. As I mentioned before, I start with my dominant hand to see where I have to be, and this is right here, as I showed before, and then I'm switching to my left hand and holding very firmly, okay, so I can get a nice picture which doesn't move, just firm. And then I will take my needle and syringe, okay, and what I would do is I will puncture the thorax and all the time try to aspirate it until the very first moment that I get some fluid, and then it's quite safe because I know exactly where I entered the pleural space. I have to palpate to say I'm in the right position, okay, and then I will just go inside. I see this white dot on the screen. I don't know if it's the tip of the needle or not, but I know it is the needle. You see, I'm moving it now, and if I did it the way I explained, which means that I aspirate all the time during the puncture, then in the first moment I feel that the fluid is coming out, I stop there and I keep taking the fluid out, and then of course connect it to the bottle I'm using. Now I'm aspirating the fluid, start suction, and we see that as the syringe is filling, the amount of fluid is getting less, and now I get the warning. So now I am aspirating fluid from the pleural fluid. I put the probe aside, it may take some time, and I'm just watching the fluid as it come out and to see if it's okay. If bubbles are coming out, this may be pneumothorax, get out. Finish the procedure immediately and just withdraw the needle. One more thing that can happen, happens quite a lot of times, is that suddenly the fluid stops. When it does, you will feel a little pinch, which you also feel in your hand, and also the pipe may slightly move. Somebody else who is very observant can also see it and say, what did just happen now? What happened is that the pleura touched the needle, okay? So what we can do is slightly withdraw it for about 1 centimeters, and most probably some fluid will come up again, and then you can continue to do it as much as you want until you are out. So there's also a part in which you can see the metrics of your work. A lot of it is maybe interesting in terms of research, of how people are learning, and what is the learning curve in terms of the way they move their hands. Most of it is not very useful in daily life, but you can see the amount of time you spent visualizing the tip of the needle or not, and that can give you some feedback on whether you are getting better or not. So in summary, I think that any kind of simulator you can use is better to do than to perform your first procedure on a patient without doing any kind of simulation before that. In this system specifically, what I like is that you get the tactile feedback when you actually have to stab the so-called patient, and it also gives you a chance to coordinate, have eye-hand coordination, which of course is useful. So thank you very much.